I'm very happy that our Wegener Center Institute is organizing this today. It's our research group on social complexity with a topic which is too hot to handle, and Illona will explain this in detail later. She's going to be the moderator, and she's the leader of our social complexity group. I'm also very happy to say hi to Katharina Wieser, who will give a presentation, and to our guest here, Jetina Tsvaki. She is here from Zimbabwe, a long way. Very happy welcome, and we're very happy to have you here. And with this, I hand over to you.
Yes, so welcome. Thank you for this nice introduction, and welcome everyone. Yes, so we will talk about heat impacts on human health, and I hope we will discuss now what can we do, how to adapt, but I hope that we will also understand that there are also biological limits that kind of determine human survival in different environmental conditions, and at the end the message is also that we really need to stabilize the global temperature, because there are also those limits that our bodies cannot cope with. And heat impact on, especially on children, pregnant women, but also healthcare workers, is a topic of a project that we participate in. The project, it's called the High Horizons, and the project funded by the European Union. And in the project, we work together with partners from different universities, different research organizations in the European Union, but also we have a few partners from Africa, because of course now Africa is one of the continents that are the most impacted by heat already now, and not even the future, but this is happening already now. Yeah, we have a guest from our partner organization, from CeSHHAR, which stands for the Center for Reproductive Health, HIV and AIDS research. Jetina, Tsvaki, who is a data scientist, educated in Zimbabwe, but also in Russia. And she's been here for 2 months. And yeah, we are working on a paper together, and I hope this is the start of our cooperation, but we thought it's a good opportunity to also organize some event where she could share her expertise. And also, of course, we have Katharina Wieser, who is a PhD student at the Wegener Center, and also in the CeSHHAR group. She finished her master degree also in data sciences here in Graz. And she just started her PhD within the High Horizon project, and she she analyzes data on the heat impacts on different population groups. Yes, so we will. I will also talk a bit more about the background, but we thought that we start with actually something fun, maybe not so fun, but like more entertaining. But it's actually a premiere. It's like it's the first time we are showing this product. So in the High Horizon project, we also made actually 2 short movies about presenting the realities of women that were impacted by heat, but also the realities of healthcare centers. And the first movie, presenting the realities of women, has been just finalized. I mean, it's maybe not the final version, but it's like a semi-final version. We thought we would like to share this movie with you. It's just like a bit longer than 5 minutes. And I think I saw already the movie, of course, and I think it speaks more than I don't know, slides and scientific figures, because it really shows like what mothers, pregnant women, what they are facing, what kind of reality, and how hard it is to them to cope with heat. But it's the first time we show this movie outside the project, so also like I'm looking forward to your feedback, and maybe we can also discuss at the end like how do you find the movie, and do you find it good, and what can be improved, and so on. So we start with the movie, right? Okay, so first maybe I will turn off the light, and like the first minute we just watch the movie, and then we will get to our presentations.
Being pregnant or caring for a baby is already a big journey. When the weather gets hotter than usual, it can make that journey even harder. Extreme heat affects the body in many ways, and for pregnant women and babies, it brings real risks. All around the world, women are finding simple ways to cope, small actions that protect their health and their baby's well-being. In this film, 3 women share how they manage the heat and what helps them stay safe.
Number 9 nditambuka nekuti kana kuchipisa ndinotsva zvakanyanya kupera mati kunzwa kuwayiwa miri wese. Kana kuchipisa nekuzvimairira nekuzvitoka kwandakaita, mama vanombondiudza kuti mbogarewo pasi muwane kutonhorerwa nekuti makaramba makamira ndopasanda kunzwa kusunguska. Mama vanonditi chimbogarewo pasi nombogara pamuvuri panotonhorera. Kana uyawo semunhu yakazvitakura ndinogona kumunzwa kuti wakanazuva achipisa stereki gara pamuvuri, kana kuti ukanozvichiramba ugara pamuvuri umbopindawo mumba mako umbobviswa hembe kumusoro pamwe unonzwa mweya uri nani kuti utonhorere.
My name is Etuida Berenga. I'm here in the Mafias, Victoria. I'm currently 36 weeks in my pregnancy, and most of the time I feel exhausted and tired. When it's really hot, it gets so difficult to do household chores like laundry and cooking because it's so hot. I don't have any traditional home remedies for the heat. I can only use normal things like drinking cold water and sleeping on the floor. When it's very hot, I usually carry my water bottle and my umbrella to keep me from the heat. And also I try to wear loose clothing so that it will be comfortable.
Με λένε Ζωή Παρασκευά, μένω εδώ στην Αθήνα, εργάζομαι ως τεχνήτρια νυχτών. Το καλοκαίρι κάνει πολύ ζέστη, ειδικά με 3 παιδιά που έχω τώρα. Όταν έχει ζέστη έξω και πρέπει αναγκαστικά να βγούμε, τις έχω το καπέλο, αντιλιακό που βάζουμε πριν βγούμε έξω. Οπότε, όταν βγαίνουμε λόγω της ζέστης, αναγκαστικά πάμε προς τη σκιά, να μην είμαστε στον ήλιο. Όταν κάνει υπερβολική ζέστη, καλό είναι οι μητέρες με νεογνά να μην βγαίνουν έξω ή να μένουν σπίτι, να τα κρατάνε δροσερά. Αν έχουν air condition, ένα ελαφρύ φανελάκι για να μην κρυώνουν και υδατωμένο θα είναι μια χαρά.
These 3 women have found their own ways to cope with the heat. Epidemiologist Dr. Sauri explains the impact of extreme heat on the body during pregnancy and how to keep yourself and your baby safe.
During pregnancy, heat can affect your health, well-being, hydration, and even lead to complications like premature birth, stillbirths, low birth weight, diarrhea, and malnutrition in mothers and their newborns. Having difficulty sleeping at night, feeling discomfort like sweating excessively, having headaches and feeling dizzy, and even early contractions are signs of possible heat stress. By taking positive steps, you can improve your well-being and protect your baby when it's hotter than normal. Firstly, stay hydrated. Drink water regularly, carry a reusable bottle, and remind yourself to sip throughout the day. And remember to breastfeed or feed your baby more frequently too. Secondly, stay cool. Find shaded areas, wear loose and breathable clothing, use cooling towels for yourself and your baby, wear a hat or use an umbrella to protect yourself from the sun. Take a rest regularly. Dip your hands and feet in cold water, and please remember, don't wrap or swaddle your baby when it's hot. Thirdly, plan around the heat. Plan your outdoor activities in the early morning or late evening when it's cooler. Fourthly, ask for support. Ask your family and friends for help, especially to carry heavy loads or water, and even to help in the household. And inform them why it's important for you and the baby to stay cool during hot days.
Okay, thank you. Yes, so it was the first time we presented the movie to people outside the project. And the first quick impressions? Yeah, it's good. Yes, I hope it's also kind of moving, but at the same time, like at the end, there's this kind of like instruction side that the movie helps women to learn like what they can do to understand the signals of heat stress and how to adapt. Okay, so now we will get to the. I will turn on the light again. So now we will. Talk a bit more, or we'll show more of our scientific results. Exactly. So first, maybe like about just the background and why we are talking about heat. So in general, this figure shows that global temperatures keep rising, and almost every recent year has been hitting the heat records. Yes. So globally. Almost each year is warmer as the year before. So it's a global phenomenon, but of course also not all areas are affected equally. Some areas heat more than others. But overall, like we have this warming of around 1.2 and or 1.4, depending which scale is used for comparison, that is already there. And it's relatively clear that if we don't stop fossil fuel emissions, the global temperature will be increasing. Yes, so this is like one of the first message that we have in the project. And extreme health already poses stress on different population groups. It causes heat stress, exhaustion, stroke, and all people, everyone who has some pre-existing health condition suffers more. But there are also groups that suffer more. Yes, so for instance, the elderly. This is also what we experience in Austria. Yeah, the elderly suffers more. Also, people working outside. Workers in the construction industry and agriculture. This is what is happening, and we can see in different data from all around the world that, for instance, people get more frequently not only heat stroke, but also, for instance, kidney disease. Yeah, because like usually they don't drink enough or they don't take enough breaks, and then like they start to get kidney problems. And of course, there's also this kind of like socioeconomic level. Yeah. If you have good access to healthcare, or if the labor regulations are good, if you can drink enough, if you have access to water, or if you can take more breaks, it's probably you'll be better off, but in some world areas it's a problem. Yeah? So people have no access to healthcare, or they have to pay for healthcare, or they don't have good access to drinking water, or they cannot take enough breaks. So this is what we observe also in the data, and there are some population groups that are more vulnerable than others. And among those vulnerable groups, so Katharina will talk more about it, there are also pregnant women or also small children. Why? So there is some research showing that in the womb, actually the temperature is a bit higher. So it's about half degree higher than in the rest of the body. So if the if it's too hot, if you know the pregnant woman feels hot, then it means like the baby is even under higher stress than the woman. And of course, also children, but the same also with elderly, they don't, sometimes they don't have this natural need to drink water, but also they cannot sometimes communicate well that they feel too hot or they feel thirsty. So that's why also children are also in this kind of, and also of course elderly, they are also in this higher risk group. And this is something what is happening right now. So you see that there are over 480,000 heat-related deaths annually worldwide. And also we see it in Europe, also in Australia, that if you look at data from different like mortality data, also the data from hospitals, you see that that people are dying or suffering or getting sick already now. And with increasing global temperatures, this will be a bigger problem. So exactly, so we need to know more about the problem. We need more data, but we also need urgent actions and policies to promote adaptation, but also climate action and lowering CO2 emissions is extremely important to lower the temperature, the global warming, the temperature increase. Okay, so Kati, I think now it's. And also the high horizon. So to one of those challenges, our project is responding, and we work together with partners from different European countries and also from Africa, and we exactly compare and analyze data from different countries, and we see, okay, are there some patterns? Is it like really happening? So at the start of the project, it wasn't clear, like, or there was like very little data available, and now actually we have the first paper with data from different countries almost submitted for publication. And we show that it's not a problem of like a single country, but it's a phenomenon that occurs across different countries. We also got data from countries outside Europe and Africa. So this is exactly a global phenomenon. So the objective of the project include to analyze data, to understand the patterns, but also to provide evidence on adaptation, so what we can do to adapt to heat. Also to develop and test an early warning system. So the idea is that we develop in the project also like an app that you can install on your phone. And if you are in the vulnerable population group, like you get messages about the weather, but also some hints what you can do, or like which time of the day to avoid. So for instance, if you need to go to the doctor, like there's a message like, plan your appointment earlier. And like in general, there are lots of kind of like useful information that are shared through this app. So this is also being developed and in the test phase. We look at different adaptation options like within healthcare centers. So some are really simple, like for instance, like better isolation, but also painting roofs just white. It's also a way to adapt. Also like vegetation, it's also known, which you I think also probably know from your own life. If there's like a vegetation nearby, then it also lowers or kind of improves the local microclimate. But maybe one more area that Jetina will later on talk about is also we ask what can be done that the emissions from the healthcare sector are lowered, or at least are not increasing. So this is also part of Jetina's work. Like she is analyzing what are the major sources of emissions within healthcare centers and what can be done to lower the emissions, like for instance to install solar panels to provide the electricity, or to optimize some processes within the hospital so that they don't require so much energy or like different resources. Exactly, we like look at various aspects, like overall at the hazards, but also what are the vulnerability factors that increase the vulnerability of different groups, the impacts, and also how those impacts are affected, like through different factors. Also, what can be done to adapt. And at the end, our goal is to provide improved knowledge, but also knowledge on adaptation, also how to help the vulnerable populations, like what can be done to minimize the risks. So that's the overall framework of the High Horizon project. Methodology, like we look at quantitative data, but we also have done some qualitative interviews, also photo voice. So also the women affected by heat, they were taking also pictures, like or photographs of like ways how they adapt. So or lots like a lot of different methods and data that we analyze. And exactly, and now I get to your part, Kati. So I hand over, and Katharina we should present more detailed results. And then Jetina will talk about avoiding emissions. Okay, so.
Exactly. As Illona just mentioned, in the next part of the presentation, I will focus on the main scopes, on one of the main scopes of the project, which is assessing the heat effects on maternal, newborn, child, and also health workers' health. And I will share some of the most interesting findings so far. First, I want to start with the results of a systematic review and meta-analysis led by our colleague Dashnika Laku from WITS RHI in South Africa. And in this meta-analysis, 189 studies on heat exposure and its impact on maternal, fetal, and perinatal health from 66 different countries were analyzed. And the main findings were that the chance of preterm birth increases by 26% during a heat wave. High heat exposure also raises the chances of stillbirth, birth defects, and gestational diabetes during pregnancy. And overall, during a heat wave, the chance of any pregnancy complication was found to be about 25% higher. Here we can also see a world map showing the number of studies included in this review. And as you may notice, most of them were carried out in China and the USA, with a clear lack of research in South America, Africa, Europe, and Southeast Asia. And so within High Horizons, we tried to address part of this gap by analyzing heat data and data on several adverse MNCH outcomes. MNCH stands for maternal, newborn, and child health, such as preterm birth and stillbirth in Europe, Africa, and Latin America. So here on this slide, we can see our preliminary findings for preterm births. In a large study of over 5 million births across 15 countries, we found that higher heat exposure in the week before birth increases the risk of preterm birth by about 10%. And the effect was stronger in Africa and Latin America than in Europe, likely due to the higher heat exposure and greater social and structural vulnerabilities. And most countries showed increased risk, with Guatemala actually showing the largest effect. And now let's turn the attention to young children. Last year we looked at all-cause mortality for children under 5-year-old in Africa, and the results of our analysis were published in the Lancet Planetary Health. Here we also see clear associations between heat and child mortality. In Ethiopia, up to 14% higher risks of death for newborns during heat events. In East Africa, 27% higher child mortality. And in Senegal and the Gambia, 11% higher child mortality during heat. We also observed some regional differences, showing that the impact of heat is also influenced by other factors, such as the strength of the health system, access to clean water, cooling and medical care, urban density, then also things like shading and green spaces play a role, or even air conditioning, and also the prevalence of diseases like malaria or diarrhea, which we found to be especially important during the rainy season. So yeah, finally, we also looked at the effects of heat on healthcare workers using a mix of methods as shown here. These include interviews and qualitative approaches, structured questionnaires, time motion studies, where we also looked at how the staff spent their day and other routine data. And we found that heat particularly affects staff in Zimbabwe and South Africa, impacting both their well-being and the quality of care they can provide. And for Sweden, the impact seemed to be a bit more moderate, and some of the results are still pending. So yeah, I think this makes it very clear that mitigation and adaptation interventions are needed, and Jetina will now talk about them.
So thank you, Kati and Illona, for setting the tone. So after then understanding how heat is influencing the pregnant women, the postpartum, and the newborn, what do we then do? So what we are trying to do then is to employ heat adaptation interventions within healthcare facilities such that it becomes more cooler. So this was then done through modeling of these designs for the healthcare facilities, where recommendations were made to then do reflective roof painting, overhang shades, like new windows, more open windows, insulated facade, insulated ceiling, air conditioning, as well as ventilation grills. So this is what actually has been done in healthcare facilities in South Africa and Zimbabwe in terms of heat adaptation interventions. So you can see that trees have already been started to be grown in Mount Darwin Hospital together with South African figure that is shown there, and also to enhance awareness to our pregnant women, postpartum, as well as healthcare workers. There are those LED screens with heat messages telling them what to do, when to do, given the current environmental temperatures. And those are men at work, like actually doing the cool roof painting in Mount Darwin, Zimbabwe. So one of the causes of temperature increase is carbon emissions, and it is then known that climate change is associated with over 250,000 additional deaths, and it is expected to reach there within the period 2030 to 250, where sadly the healthcare sector is responsible for 4 to 8% of carbon emissions. So what this picture is trying to say is there are many areas from which healthcare facilities emit carbon emissions. That's through their transport system, the energy which they utilize, and even some of the activities that they do, they emit carbon emissions, which then gives rise to temperature. So given also the context that within healthcare facilities, especially in the low-medium countries, they tend to emit less emissions vis-a-vis to high-income countries. So why then are we trying to focus on reducing carbon emissions in these areas? It's because, number one, there is expanding population and UHC growth, which is universal health coverage. So as the population within low-medium income countries tend to grow, there's also going to be a push to attain the universal health coverage, thereby driving emissions higher. So there is need actually for us to reduce emissions in these facilities. Number two, some of the interventions such as solar systems, they tend to come with core benefits. For instance, over time, we can actually save costs with installing solar systems, and some also provide heat adaptation interventions. For instance, tree planting, it also provides that shading. And decarbonizing healthcare facilities also helps to achieve global climate and youth commitments, thereby improving our health outcomes. So under this High Horizon project, as a part of it in trying to reduce carbon emissions, we use this pipeline where we first measure carbon emissions. Our understanding is we cannot reduce emissions if we've never measured them. So we first measure emissions, we design interventions that are context specific and also that are cost effective. We implement them and also evaluate their effectiveness and disseminate results, just like what we have done by showing you that video of some of the findings that we have found within our projects. So when assessing carbon emissions, we did this in 8 facilities in 3 countries. That's 2 in Kenya, 3 Zimbabwe, and 3 in South Africa. And they did have different topologies and different locations. Some were from rural areas, some were from urban areas, and the facilities had different types, some private, some public, some secondary, primary, as well as tertiary facilities. So we managed to measure for all these 8 facilities. And they did also have different ranges of average patient throughput, right, ranging from 7,000 annual patient inflow up to 168,000, with different main energy sources, as we have known that fossil fuel is one of the driving force of carbon emissions. So they is also included in assessing carbon emissions. So these were the results that we got when we assessed carbon emissions in these 8 healthcare facilities. And just to take you back a little, you can see that we had Mombasa had the highest emissions in Kenya, which is a tertiary healthcare facility. It emitted over 8 million kgs of CO2, given to its size number 1 in terms of patient throughput, as well as different types of activities that are done at a tertiary healthcare facility. And also we had Chitse with the list because of its size, as well as it is a primary healthcare facility. Then this is just a picture to show you how carbon emissions are being assessed at each and every healthcare facility. And these were the areas that were measured. In particular, this is Mount Darwin Hospital. So in terms of the design, we understood the context from which we were working in. We are working in an ill-resourced environment. Thereby, it needed us to be very strategic in terms of our investment for carbon mitigation. If we do have got tight budget and we also have climate goals, how do we then invest our interventions? So we then developed a tool called Carbomica, which aims to guide decision makers where to invest for maximum reduction of carbon emissions. So this is the results that came from Carbomica, where you can see that it shows at different budget scenarios with different types of interventions, where budgets, where investments rather, could be set for maximum reduction of emissions. So this one is for budget allocations, where should money be focused at different budgets and different interventions. And that other graph, it then shows the carbon reductions per each budget allocation. And this table explains better how our model works. So it's saying if we do have got $3,000 US, we can have a reduction of 4% when we plant 200 trees and also have waste segregation. And at 5,000 budget scenario, it can actually reduce emissions by 6%. When we install a solar system and we plant trees, and we also have that access. So this is how definitely this too is guiding how investors or decision makers can implement carbon mitigation interventions for maximum reduction of emissions. So In Zimbabwe, this is what we have done after we got our recommendations from Kabomika. We then implemented these interventions. So these were waste segregation bins that were supplied to all the three healthcare facilities, energy efficient refrigerators, and that was tree planting that was done. And also we had engagement and awareness workshop to make sure that our stakeholders understand why we are doing it, and also to make sure that it becomes sustainable even after the High Horizon project. So what were we talking about all along? So we do have got three key takeaways, which number one, extreme heat is increasing the risks for pregnant women, postpartum, newborns, as well as the frontliners, which are healthcare workers, linked to preterm birth, which Kati has mentioned about, stillbirth, dehydration, which has been illustrated before. And our healthcare facilities, they tend to amplify this risk, especially if they are poorly ventilated, unreliable power, etc. And our current data and warning systems, they tend to overlook this. So these then cause for us then to act towards to reduce heat-related risks in MNCH. So we call that we research more on the influence of heat on MNCH, and also invest in mitigation and adaptation interventions to make sure that our environment are sustainable, and also that we are reducing emissions and yet adapting to this new problem. So this is it. This is the work that we are doing, and it's an honor that we managed to share our work. Over to you, Illona.
Thank you. Yes, so many thanks to Kathy and Jetina. Like in my initial talk, I forgot to mention, of course, also healthcare workers as one of vulnerable groups, because like you can imagine, like if it's hot, like also more patients come to the hospital, like also they are the healthcare workers on kind of the first front line. And of course, in many hospitals, like there's no air conditioning, or like we've heard those cases, like there's air conditioning only in the director's office, but not like in the labor rooms, like when women deliver babies or where patients are treated. And often, like we heard those stories, because we also, like within the project, we visited also some hospitals, so we had those stories that women, like healthcare workers or doctors or medical personnel say like, well, you know, one of the solutions is like drink more water, but then they say, but then I have to go more often to the toilet, and then like, you know, I have to leave my patients alone. So there's also like this pressure, okay, I cannot take so many breaks, so maybe I don't drink enough, you know, not to have to go to the toilet so often. But at the end, of course, you know, the health of the healthcare workers also suffers. So it's very complex. Yeah, but I hope we managed to give you like a good overview of the problem, and also show the results of the project, and also some ways to adapt and to mitigate. And what I especially like in the in Jetina presentation, that it shows this kind of active role, that we are like not only like exposed to climate change and overwhelmed, and like what should we do? Should we wait for the governments to take some decisions? We know it's not working. But it showed this active role that really like hospitals or different organizations, they can take the action in their own hands, and they can adapt. They can also work on their own level to reduce the emissions. So I think this is like really the sort of like there's this agency component, that you really you can search for solutions like at your own level. But of course, the support of governments and international organizations is also needed. Okay, so I'm looking forward to your questions, like maybe you have some clarification questions, or something, maybe what was not clear, or maybe you would like to share some comments.
Thank you very much. Very, very, very interesting. And as you showed before, it was already, so the suggestions and the measures were already taken up by some hospitals in Zimbabwe, as you showed. So my question would be, how was this taken up, or how is it taken up by the leadership? obviously the workers will take it up positively. What about the leadership and how could you roll this out to more institutions?
Thank you so much for that question. So the leaders has taken this very well in the sense that like number one, the head of state, the president himself, is supporting this work. When CeSHHAR was done, he was part of it, like the very first climate and health conference in Africa, he was part of it, endorsing this work that is done in Mount Down Hospital. Then secondly, the local leadership, definitely they are part of this work and they are taking it very well, because in terms of framing the interventions themselves, they have been participants of that work because we were using this living lab approach whereby we don't create interventions for them, but we create interventions with them, for them. So they are part of the work. All levels, like from local level, traditional leaders, the municipalities, even at policy level, they are part of this work. And just to add, like on carbon emission assessments, some of the people who are helping us in measuring carbon emissions are the leaders within this ecosystem. So they are taking it very well.
Mm-hmm. So it's also something we went last year in November, like we had this big conference, also project meeting, and we also went to see the hospital in Mount Darwin. So I have to say I was quite impressed that it was obvious that the project team in Zimbabwe had like very good relationships with the hospital, with the local community. So there was like even like a welcome by the local community with like some school children, singing some songs, and also like a local market. So it was really, really nice. But it showed that there is this, and we also planted trees together and had a meal together. So it was like it showed that there's really like I think trust and like longer kind of relationships between CeSHHAR and the local community and the hospital. So this was really nice to see.
Mm-hmm. Yeah, thank you also from my side for this really nice talk. It was very enlightening and also somehow really like motivating how researching also looks. So it's very nice to see a very complete project, and I wish like every research project would be like that. But and I really found it interesting how you like combine all these stakeholder things and the house design and did workshops and this movie in the beginning. So it seems like you really have a broad palette. I have actually a very small question only, but maybe I missed it. Like, how many hospitals or healthcare facilities did you work with so far? And is there any more plans? Like, where in which countries are you working?
Okay, thank you. So for Zimbabwe, we had 3 healthcare facilities that we worked on. That's 1 secondary healthcare facility and 2 primary healthcare facilities. But the plan is then to expand. These are acting as our action research labs from which we can learn what's doable and what's not, and then over time we then replicate them to other facilities. So that's where we are. In South Africa, there are 3 facilities. Then Kenya, there are 2 facilities. Oh my God. Yeah, maybe this one summarizes better. This one. So these are the facilities that we are working on under the project. And you can see that it has got different topologies. some are private, some are public, some are tertiary. So our model works in any kind of a healthcare facility.
And so because you do the carbon assessment there, is it also the ones when you do like adaptation measures as well? So this kind of goes hand in hand, or?
So for adaptation intervention, the approach was kind of different. So we didn't use this pipeline. So it was more of the qualitative concept. So we had to engage the pregnant women, USG analysis, the urine.
There were but the adaptation was also applied in those healthcare centers,
Yes. Or if that was your question, then heat adaptation interventions were actually implemented in these healthcare facilities. More than 20 of them, I just shared 3 of them, multi-leveled, multi-tiered, like some could focus on policy, some on the facility, some being like, what do you call them, some infrastructural, some nature-based, like tree planting. So we had over 20 adaptation interventions at our healthcare facilities.
Yes, really quite important. So sometimes there's argument raised that the healthcare centers are not responsible for such a big share of emissions and like as it were. But I think there's this argument that in many countries in Africa there's like a rising population, but also the kind of population is increasingly doing better economically. So like this demand for healthcare services is rising. Yeah, so this is also important, like both for adaptation and for mitigation. And that will be like a sector where there will be expanding. There will be more hospitals built, or the existing hospitals will have to expand. So there's definitely like a high demand. I mean, like regarding your first comment that it looks so convincing, but we are in the final stage of the project. It's the last year. But like really the second year was like, because it's so complex and like different teams, different countries. And also we often have also connection problems. So when we have Zoom, so most of the time we of course try to work online, not to travel so much. But like very often like we had problems that we had Zoom calls and like there was a power outage or no internet or the connection is not stable. So like the first even like 2 years was like just kind of trying to figure out how can we work together, how to make sense of that. Also problems with data availability was like really bad because like this data, it's not like you click and you get data on premature deaths in all over the world. Like we really had to talk sometimes to hospitals, sometimes with statistic office at the national level, or some other agencies, like also with the World Bank, not the World Bank, the World Health Organization, to get the data from different countries, from different regions. And the next problem was that the data was very often not compatible. So there was like different definitions of different time periods used, or different resolutions. So it took us also like a long effort, like just to kind of homogenize the data and like put it all together so that it can be used in one analysis. And now we harvested the outcome. So it looks. I was impressed myself, but for but for a long time, like we were trying to find our way through the project and deal with all the problems like data access and just communication within the project and so on. So it's quite challenging.
Yeah, thank you. That actually answers the question I asked because, like, especially what you talked about, Kathy, where you calculated the premium risks, etc., etc. Like, is that data that is standardized, available standardized? Yeah, of course. No. But I really enjoyed the presentation. Thank you. It feels very actionable. Like, it feels like you can say, this is the outcome and this is what we can do. And these are the cost benefits and co-benefits, and these are like this is why we are doing it because travel health, etc. And It looks very clean and easily understandable. Thank you. I'm sure it was a lot of work.
Yeah, and we still like in this cross-country analysis, still like Austrian data is not integrated because it turned out that the Austrian there's something you want to say tell more, but there's some problem like in the data and like it didn't make sense like when we started to analyze, so we had to exclude it. But it's like something what's ahead of us, and also it's Kati's PhD basically to try to do this analysis on Austrian data. Exactly. So. Because it's like now it's winter, of course. it's cold, but like there are heat waves, of course, also occurring here, and it's something what's like every summer. It's a problem. Yeah, so okay, more questions, comments. Mm-hmm.
Yeah, hopefully, I didn't miss my question. So sorry if I missed it in advance. Is there what's the comparison data? So is it reflecting the whole population of these areas? Are there rich people that go to other institutions and don't have these problems? And where is it to what compared to what is this mortality risk? Is it just compared to before or to some other people?
Yeah, understand the question. Of course, there could be like different methodological approaches to have some comparison. There are also those kind of attribution studies that look more like which heat events can be attributed to climate change, which not. But like in our case, like we look, maybe Kati will tell more, but basically the comparison, like we compare the health outcomes, like mortality or premature birth or other data, like we compare it with with different temperature records or also humidity records. Yeah? So basically, like we look at different days, and the question is like, okay, on days with unusual heat, do we observe that more babies and women lose more blood, or like more, or the liver takes longer, or maybe babies are not doing so well, or some unfortunately die. So this is like our sort of comparison.
So it's an intra-year comparison somehow.
With different days and different temperature, humidity records. Maybe Kat, you want to add something?
Yeah, what you said, but there's like different ways of doing this. There's different methodologies, and what we use for this preterm birth study that I showed is like a kind of case crossover design. So there, the woman gets compared to herself, basically, as so she serves as her own control, but with like two different temperature values.
It's interesting. And regarding the question, if it is just poor people, and if there are some rich other institutions where you could eventually change, or is it
so it's a bit more complicated because when the hospitals record the data, due to different issues, they basically just record like the age of the woman, like maybe which child it is, but they don't record data on the income or type of job. So it's a bit more complicated. We don't have such good data there, but there are some extra surveys that we run within the project to collect this data. Also, there are some databases where sometimes, like collected by insurance companies or other organizations, where sometimes you can get more of the socioeconomic background. But I think the surveys are not analyzed. They are run, but I think the results are not available yet, right?
So part of them, if I got your question correctly, like are the rich also affected maybe by extreme heat? Is it?
Maybe you could ask it like that. I didn't want to say it like clarify it like that. Yeah, but maybe it's.
But in some way, it's. I mean, yes, because like if you have more resources, you can adapt better. You can. You don't maybe have to work so hard physically, or you can get help of someone. So in some, or you also maybe don't do some types of jobs that are most risky. Or also like maybe your house is like better isolated, or you have air conditioning, and if you have less resources, less capital, of course you are more affected. But we run those surveys, and certainly because I started.
So part of our sister project, HAPPY, so we have tried to assess extreme heat on USG, that's urine. So we tried to combine for the Zimbabwean data as well as the Kenya. So as she mentioned that some of the evidence in South Africa, they were not so evident that extreme heat is influencing USG, but in Zimbabwe was very dominant. So when we then combined, we realized that country also had influence, reason being facilities in South Africa, they had better infrastructures, and also they are in the city, they had air cons, vis-a-vis the ones that are in Zimbabwe. So definitely that component, it also affects the outcome ultimately, because these ones are not exposed to heat adaptation interventions, and these ones, they are exposed, thereby the outcomes will definitely going to be different.
And how many percent of the births are done in such lower infrastructure hospitals compared to the complete rate of birth? So maybe you could set it in a relation to how many child are born in an area compared to what you observed. Is this possible, or is there no information about it?
I think exactly, maybe you know more, but in general, maybe it's also location dependent, because if it's a rural area, there's usually just one hospital that you can go, and the hospital most of the time is not so well equipped. But of course, in urban areas, you have more choice, and sometimes, if you have maybe better insurance or private insurance, you can go to a hospital that is better equipped. Yeah, but you basically have more choice. Yeah.
So eventually you could even have a home birth.
Yeah. So definitely, but I think we have no data to.
Yeah, it would be really an interesting area to lean on how inequality is playing its role within this problem that you are currently having.
That's the interesting part about it, yeah. So what I try to figure out a bit.
And I think, coming back to your original question, there might be some type of bias in there, of selection bias, because the births that we're recording, I don't know, I can't speak for the other data, but for the data from Austria, it's insurance data. So it just captures the births that were kind of abgerechnet with the insurance companies. So if you have a private insurance, this might not be accounted for in this data. And that's a very important point, actually.
Mm-hmm.
Yeah.
But just yesterday, I saw a paper with analyzing data from France, and the outcome was that there was no a significant influence of the socioeconomic background of the woman. But it was in France, so I think quite different conditions where people live. Of course, there are richer people and poor people, but there's no a kind of extreme poverty. Yeah, and more or less everyone is insured, everyone has access to healthcare. So they didn't find significant influence of socioeconomic data. But I think it would be different in countries with that where health insurance is not common, or also there's more socioeconomic differentiation, more poverty also.
I would also imagine that there's some kind of limit up until where you can account for more heat stress, for example, with your social and economic status, and then it gets to a point where you will suffer anyways.
Yeah. Although not to some extent, yes, you can. If you just stay in air-conditioned rooms, and if you travel by an air-conditioned car, you can protect yourself to some extent. But of course, there will be more and more pressures. Yeah, also all kinds of pressures. So up to a point, and also of course, this also imposes costs on the healthcare. Yeah, so the question is what's the capacity of our healthcare system? How long can it go? If you have more and more patients, and especially those periods with many patients and many children in different groups suffering, and also the healthcare personnel not doing well, and so on. So it's a question of kind of overall stability of our and resilience of our systems. Do we have more questions? Okay, so now, I should say, so when Jetina arrived here, she brought for our project team like nice t-shirts from Zimbabwe. And I thought like we do like t-shirt exchange. And Jetina, we bought you like a t-shirt from the University of Graz.
Thank you so much.
We also have a cup for you. So, yeah, so thank you, Jetina, for being there.
Thank you.
And it was so nice to have you here.
Thank you so much.
Yeah, I hope it's just the start of our operation. And now we can exactly like wear t-shirts.
Thank you so much.
You can wear a t-shirt from the University of Graz too.
This
when we
is
meet
so
again.
nice. Yeah.
So thanks a lot, especially to Jetina and Kati for presenting their work, and thank you, Veronica, for organizing the talk, and Mattia. Thanks a lot.